Hello everyone, welcome to another episode on the Day with Your Fertility Specialist. We sincerely apologize for the delay. It was due to some technical issues, but we're so glad to have you all here with us today. So please do also share this link to your friends, to your family members, to people that you love and you care about, so that they can also benefit from this impactful session. So as we all know today, we're going to be talking on evaluating infertility, and to guide us through today's session, we have with us our lovely Dr. Kenneth Pekuda. Thanks so much for being with us here today, sir. Right. So we don't waste too much of your time, we're going to jump right into it. But can you please tell us, at what point, not in this part of the country, this part of the world, we we believe we have faith a lot. And then when things like infertility happen or delay in conception, people tend to pray and then say something to God. So at what point do you think couples who are going through such should actually seek medical help?
Yeah, important observation. Quite a number of people have faith that they have to wait on their belief system, you know, to see if they could work it out that way, which is okay. You have to become to something at any point in your life.
Yeah.
So it's okay to have faith, to wait. Yeah, but there is no particular duration of time that one should wait. Yes. And then for the doctors, it is not too early for anyone to just come, to work out fertility problems. You know, for me, I think that when a woman thinks she should have gotten pregnant and then she's not pregnant, it's just a good time to just seek for help. You know, but when we're in medical school, for instance, or rather when we're doing residency training as young gynecologists, they'll tell you that a woman has to be waiting for a year, you know, and then having regular intercourse, with her partner, and pregnancy not happening before she sees the specialist, And now they categorize it also that when she's 36 years, she doesn't have to wait for a year.
Okay.
Then she can just wait for 6 months before seeing the doctor. But then in the real practice and understanding of gynecology, for instance, and fertility medicine, uh, attachment of timelines which makes no single sense. A woman may be 3 years. I mean, newly married, and she has done 3 months and hasn't gotten pregnant and is worried. Yeah, she's worried. She should seek the doctor's advice. And now the advice doesn't mean she should be forced to do something crazy or something very invasive, but at least to evaluate her for what she is and then to reassure her whether she needs to wait some more or whether some invasive or detailed evaluation and treatment needs to be given. Now, I also feel that some women can actually even start seeing the doctor, the specialist on fertility matter, even before their wedding day.
Wow.
Because a woman needs to understand her body and knows what time in life, with respect to her fertility life, she is when she needs to start thinking of making babies. Because if you're married at 40 years plus, for instance, I think you should start seeing the gynecologist even to plan pregnancy before you get married. So putting timelines to it, just as you asked me, makes no sense to me with the level of my practice. Because even when a lady is 20 years, for instance, and then she stayed for 2 months, 3 months, 4, and not having pregnancy, she should consult her gynecologist. And then because even at 20, a woman could have very serious reasons for not getting pregnant that will warrant some invasive procedures to assist her to get pregnant. She may be normal on her own, but at 20 years, her husband or her partner may not have sperms. So how long do you want her to wait? So there is no harm in seeing the doctor immediately you think you have a challenge, and let the necessary basic investigations be done, and then you find a reason why you should wait or not.
So what
But
about
putting it for 1 year makes
no
no
sense?
fertility sense to me. And I think a good number of my allies who are experts in the world of reproductive medicine will share my sentiments. So the definition of 1 year or 6 months for others is just academics. It doesn't have a place in the practice of reproductive medicine. A delay is delay, and they all have something in common, which is anxiety.
Yeah.
And anxiety is a big problem. You know, it could affect your productivity in life. It can affect your output at the place of work. So check out these couples as soon as they come. And I've seen some people, some gynecologists, for instance, see a lady who hasn't gotten pregnant because she's young. You've stayed with your partner for a year, and then you're not getting pregnant. And they say, I know you asked, everything is okay. Go continue trying for some more times. And when you're getting older, you come, well, that's crap. That shouldn't be done. Evaluate the couples as soon as they present themselves, and put them in the right path, because you will never know. There could be a huge problem that may just persist for the entire length of time you ask them to go to
And
it.
it will just get worse
It
as the
just get
time
worse,
goes.
exactly. For instance, if you ask a woman to go wait for a year, you know what it means? Each month she is having a recruitment of her eggs, and wasting them. And the eggs she wastes this year are of better quality
Then the one of next year.
than the one of next year. So those waiting period may actually be counterproductive. Yes, it may not be very helpful. Well, I think women should one day tell us how they feel when they leave the doctor's office and he asks them, go and wait. And apparently they waited for a year, working it out with their spouses, and then no pregnancy is happening. I could speak on and on and on this matter, and I'll bring out a lot of social perspective why people shouldn't wait. For instance, you're married to a guy who lives abroad.
I was going to ask about people that stay far away from
Exactly.
each
So you
other.
see, you have to bring the peculiarities of each of these couple or partners, into the picture. If a man stays abroad, for instance, and the wife is locally resident, you know, it means you should think around their peculiar circumstances. In fact, after their wedding, if you ask me, he should deposit his sperms,
Yeah.
and then he can go wherever he wants to go to. He should deposit it in a fertility center where his wife can easily access it. Because the days are past that you say women have to have intercourse before they get married. Before they get pregnant.
True.
You don't need intercourse to get pregnant. Just communicate the hospital or the facility and sign a consent, make my wife pregnant with my sperms and all and all and all that. And then it's done. It's pregnancy by proxy. That's the world we are in. After all, you can call a friend from whichever part of the world. You can even call a friend from outer space, and have a communication. So you can also call, and then the fertility center makes your partner pregnant on behalf of you. On behalf of you.
Just keep you properly informed.
Exactly. If you are in doubt, you could do a paternity test. So you see, it's actually quite dynamic. Asking them to wait can be emotionally counterproductive. Yes, and you could cascade the couple's problems. You really don't know. So it's good to evaluate them and know what's really going on before you make a decision. If they choose to wait, they choose to wait. So those definition of 1 year, 6 months, and all of that, to some of us who are experts in the field of productive medicine,
Rubbish.
is just not good enough.
Okay.
Yeah.
So for people that are, having infertility, when they come to the hospital, what should they expect? What is the modality of treatment? Are there special modalities according to males, females? What should they expect?
All right. So what they expect usually should be that they see the doctor first, and then the doctor takes history and asks them about their life generally, the life as young teenagers, as adults that they are, and their reproductive life generally. You understand? We ask all kinds of questions, to ascertain whether or not their reproductive physiology is going on fine.
Do people lie about their history?
Yeah, a lot of people lie about their history because they probably don't understand. I have seen people who would I say lies, but it sounds like lie.
Fabricated truths.
Yeah, I like that. They don't really lie. When Donald Trump assumed office, there was the slang that they brought. Or is it? What's that slogan in Donald Trump's office now? His first tenure was like alternative truth. Yeah, it's an alternative truth. And in Putin's office is ultrasonic truth. No, he doesn't lie. He doesn't lie. He only speaks ultrasonic truths. You're fine. So I think the women don't lie. They only say ultrasonic truth or alternative facts. Yeah, that's the word, alternative facts. Then you have this woman. How old are you? She said, okay, Dr. Ken, I'm going to tell you my age, but I need you to hold your ears. I'll just give you a heavy grin. At this age, I'm telling you, my husband doesn't know it. I say, okay now. I don't know, I'm used to this scenario. You're not the first. And the age doesn't leave this office. It's not even in your document.
Patient's
Confidentiality. I say, okay. But the age you're going to tell me is going to affect every decision. Okay, I'll tell you my two kinds of age. Which age do you want? Is it the official age or the biological age? I say, I think it's the biological age I want. Okay. My biological age is 47. But my official age is 36. I say, all right. I'm going to write 36. But between you and I, we know that you're 47. Oh, Lord Jesus. All right, so that's just to put it in a lighter form, okay? Yes, people say alternative facts about their age, but then it's good to be open to the reproductive physician, because age has an implication with reproduction and the modality or the style of fertility care that should be administered to you. So we find out the age, and some actually don't tell the complete history. For instance, a woman may not tell you that she had a D&C several times. Some want you to find out for yourself, and they think that asking you to find out for yourself is going to make your judgment of them correct. They don't want to lead you. The doctor is not a magician. You have to tell him what there is, because there are some signs that we find, and then we need history to verify the facts. Like you see a woman that's having a scar in her youth, she says she hasn't done any procedures. How then the scars? Did the scars go there? Were you just born that way?
Or people that have skipped periods, missed periods.
Exactly. So, you just have to tell everything that the doctor needs to know, because every single thing has an implication with respect to your reproductive history. So first of all, we'll take their history, how life has been generally, because the history you give will affect the kind of evaluation, testings, procedures that will be done for you. For instance, you know that when a woman has a D&C, evacuation of the contents of the uterus, sometimes it can be overzealously done. You understand? And then you could leave a woman with uterus, but she doesn't mention it. You not know what kind of investigation to carry out to evaluate her. So some, I understand, may not be able to tell their histories when their partners are there. So there are some of this history you want to get when they are alone, and then they'll be free to open up and tell all the history. But it's good to know that you need to tell every of this history. Then the history helps to correlate investigations and procedures that will be necessary for you. So we ask the age, very important. We ask the gynecological history for those of us who are specialists in gynecology. We may also want to ask medical history. The medical history, for instance, like whether or not you are diabetic, hypertensive, and because each of these information has a bearing on what kind of care you will get before fertility treatment and when you get pregnant and after pregnancy. For instance, there are some medications that you take when you are hypertensive that may affect the development of the baby. And then it's the role of the gynecologist or the reproductive physician to switch those medications to safer ones before fertility treatment commences. Otherwise, it will be counterproductive. You'll be putting the babies at risk and the pregnancy at risk eventually. So we do all of this history, and this history help us to know whether or not we should do this or not this. For instance, if a woman has had D&C one or two times, she will need to have what we call hysteroscopy as part of her evaluation. Now, the blood tests are regular. It's okay to do the blood test. And the blood test doesn't necessarily mean that we must find an abnormality. We don't have to find an abnormality in the blood test. One, because the blood test could be medical legal and could help us in forecasting the health of the pregnancy should pregnancy occur. As simple as the thyroid function test, for instance. If the thyroid function is deranged, you could have every good treatment and get pregnant and get miscarried immediately or soon after. So all these tests, the sugar test, the kidney test, test for infections, chlamydia tests, the tests are just numerous, and the tests are dependent on individual. No two persons may have similar testing if they are being cared for in the most professional and individual way. Now, this is different if you are being cared for by a trust or an insurance system that would just categorize everything and say, this is what should be done for you. You have to treat people as individuals. What will be beneficial to you may not be the same thing. And that's to say, two people may spend different amount of money in a private setting just going through evaluations, because what is needed to evaluate you may be different from what is needed to evaluate the next person. And then the content of your history will also determine other ancillary investigations or evaluations that I mentioned earlier, that if you've had frequent miscarriages, for instance, frequent failed IVF treatment or D&C or fibroid surgeries, you may need hysteroscopies to see whether the lining of your womb is fine. And then from this part of the world, a lot of women have had miscarriages. And then one common thing that goes on with miscarriages is that the content of the uterus is being evacuated, and some just get pregnant even at their teenage age. That's to say, even the life you live as a teenager or a young female adult can have a beard, that's the word, could impact on your current fertility state.
Wow.
A lot of girls have had a termination of pregnancy, D&C, or manual vacuum aspiration. And then our tendencies to forming scars are different. Some ladies may do it 10 times and not have a single scar. Then some other ladies may do it just once and then have terrible scars. And these scars, to a large extent, are incurable. It doesn't matter how much intervention you give into these scars in the uterine lining. You can just improve it to the extent that is possible. And some are just impossible. So you evaluate. The reason for the evaluation is to know this person and then know the kind of care that this person could need. And also to be able to explain to the person when he or she succeeds or fail, the reason
Reasons
why
why.
these things happen. So this brings me to the point that sometimes I find it a little bit frustrating when some doctors, sorry, I'm a doctor too, some doctors, why you don't succeed. Yes, there could be reasons why you don't know why success happens. But most times you would know why success doesn't happen. If you do every kind of analysis that is necessary, including genetic testings, because most embryos are genetically abnormal. Then a good number of people produce the eggs at old age. Then the husbands are advanced age. And then we ask men also their age. And once these gametes are not of sound quality, are not crystals in quality, like those of the angels in heaven, pregnancy may just not happen. So it's unscientific to say, I don't know why you don't succeed. If you look closely, there is reason for everything. So saying that we don't know is unscientific. We always know. We may not be very glaring, but there is always a reason. So evaluation is limitless. I've talked a little about the woman. It's so important that even the periodicity of a woman's menstrual cycle should be able to ring a bell. For instance, a woman may say that I menstruate for 8 days, and it comes with clots, and I have to use how many loads of sanitary pads. Of course, even if you are a dumb gynecologist, you should know that you need to look into the uterine cavity of this woman. Even if ultrasound scan and every modality of scans shows that she's normal, she is not normal. How can you menstruate like that as if somebody is slitting your neck? And then they say it's normal. I didn't know. Check it and look for an abnormality. It's okay if you check and you don't find, but it's not okay when you don't check when there's a problem. So when the menstrual cycle or menstrual flow is not normal, you should check why it is not normal. And in good occasions, you would see the reasons. Even if there is no physical growth that will make your woman menstruate that way, you should take a biopsy of the
Of the
endometrium,
tissue.
of the tissue, and do a histopathological evaluation to know whether the tissues are growing well or not. Otherwise, you may not be able to guarantee that you do a very befitting IVF treatment and this woman is going to get
So you need
pregnant.
to cover all your
You need to
bases.
cover, and that is why evaluations are limitless. Sometimes you need to even do tests for abnormal killer cells.
Okay.
Yes, like a natural killer cells. Because some people have autoimmune conditions that wherever he see primitive embryos,
They terminate
it
it.
terminates it, it kills it. So you check all of that. So that's to say, when women sometimes, it worries me when women call me on phone and they say, how much would the test cost? I say, I don't know. I said, how, are you dumb? Why are you saying you don't know? I don't know. I haven't seen you before. I've only communicated, I only know your voice, which is not even of any significance to a large extent in fertility care. Except, of course, if the voice is sounding like a man's voice, I know that I have to do testosterone and androgen testing for you. I've only heard your voice, and you're asking me how much would your test cost? I have not scanned you. I don't even know if the history you're telling is right history. I don't know whether you've done some pregnancy losses or terminated pregnancy, and you're asking me how much your evaluation will cost. I'm not working for a trust. I work as a clinician and as a scientist. I need to see you and make diagnosis and know what to do for you. So I don't even know. Yeah, this doctor is hostile. I'm not hostile. I'm just being scientific. So you can't tell because you may just say, okay, it's going to cost you $10, and then you see a problem that is beyond
$10.
$500, and the woman says you've told her lies. No, I haven't. So evaluation, first of all, is individualized. It's dependent on you as an individual, and it's dependent on your partners. There are some male partners, for instance. Before now, we men feel we're superhuman. I also feel I'm a superhuman sometimes, and I'm serious about that because I'm extraterrestrial. Yeah, and then you come like a hunk, you know, you feel everything is fine, just check this woman out for me, you know.
I was going to ask about men because you've been talking women, 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 women.
Yes, now
So
I'm on the
let's
side of
come to your
women. Let's talk
side.
about the men. For the men too, first of all, analyze their sperm. The sperms gives us an eye into the man's life. Yes, the sperm gives us an eye into the man's life. And these days it's difficult to see normal sperms. Yes, it's difficult to see normal sperms. I agree that all men have some degree of abnormal. Every man has some degrees of
Of
abnormal sperm. So
abnormality.
long as you are living in this world that is full of stress and the stress is still mounting, it's full of abnormal sperms. I mean, some degree, but then it's to an extent. But then it can get beyond normal, the level of abnormalities. You know, when the sperms are now looking lower in count, the movement of the sperms are abnormal, the shape and the morphology of the sperms are normal. We look quickly into the man. What's your lifestyle like? Do you drink? Do you smoke? And then we'll begin to try to see how we can modify. And again, a good number of men also do not marry until they are old. Now men have biological clock, and I'm saying it again and again, and that's true because pregnancies rates are lower amongst men that advance in age. So it's also good for men to have babies when they are young. That's true. And it's scientifically backed. And also, the older the men get, the more deletions they have of their Y chromosomes and a lot of abnormality because we're exposed to all kinds of radicals in life. And our stress level is higher than the woman
Especially in
because
this part.
we are hustlers. I'm also a hustler, you know. Sometimes I wonder what my sperms look like. Yes, I'm talking about looking at it under the
Yeah, I
microscope.
can bring it to us. We'll check for you.
On a normal day, on a lighter note, sometimes I and the team of embryologists that we work together, you know, maybe we're doing a big cycle of treatments, you know, and then we have like 40 different sperms from 40 different men in a day. And then I have 2 kids, so I'm not very worried. When I look at all the sperms, and then the embryologist goes, man, these sperms are not looking too great. I say, well, I think sometimes we should also check our sperms and see, because the lifestyle we live may have a lot of negative impact on these sperms. We don't sleep enough, so much volume of work to do,
Stress.
so much stress and all of that. So when we have abnormal sperms from men, for instance, we also ask them these questions. Are you on medication? And sometimes I send them back to their physicians to care about the medications because a lot of men are hypertensive. Right from the age of 30, our stress level it begin to mount.
Goes up.
You know, now you are hypertensive and then you are on all kinds of medications. And then a good number of these antihypertensive medications are not friendly with reproduction, whether for the woman or for the man. You know, sometimes I send them back to their cardiologist. I say, go tell your cardiologist that Dr. Kenneth Iguda is requesting that your medications
They
are
changed.
edited. And the cardiologist says, what's wrong with this medication? I said, go down, tell him to look at this medication and how they affect reproduction. Because some of these medication, especially the angiotensin converting enzymes, inhibitors, you know, the AC inhibitors and all of that, they have negative impact on sperm's growth, development, and
Wow.
expression. And then you're going to do IVF with a sperm that has been exposed to this kind of medication, you know, then you're reducing the chance because the sperms,
Success.
you need healthy sperms to make
Healthy
healthy outcome of
babies.
pregnancy, you know. So, and now I'm glad that those cardiologists close to me are beginning to understand that these medications are not healthy. So when you take the history of the men, their drug history, lifestyle history, we begin to edit them. And when you see sperms that are not moving so well, they're moving as if they've suffered from polio, you know, you also want to check, scan the scrotum, whether there are abnormal physical abnormalities on them, like abnormal blood vessels and all of that. And then you correct that before going in for an IVF. So Doing this evaluation in Alps Hospital, for instance, can be very tedious for the man because you wonder that you're just going to give us sperm. Yeah, if you give us sperms and we see that the sperms are not all right, we look further, deeper into reasons why these sperms are not okay. Because we may need to address that before an IVF treatment is done. So you probably come with the mind of doing your sperm analysis, which is a few amount of dollars. Then Ken and his team are requesting we need to do an ultrasound scan. You wonder, you didn't do for this man. Yes, you are different. And then we need to even do your hormone profile as a man to see. We need to do physical examination and feel the way your testicles look like. We check everything, by the way. Yeah, we do all of that. So that's evaluation, and that is what to do. When you've done everything and then somebody fails, you don't feel guilty as a physician because we have conscience. And the conscience now depends on how much you know. So you need to express yourself, do everything, and be satisfied that you have treated this individual and you have justified the amount of monies they pay. Yes, you could do all of this and still pregnancy doesn't happen because there's a lot involved in getting pregnant by assisted reproduction technology or just by any means. So those are some of the things you do for evaluations. Some people are on antiviral medications, the HIV medications. HIV medications fight against the human cells. You could get pregnant with some people can get pregnant with them. Some will have challenges getting pregnant. So we talk this detail, and you can see that is why in the organization where I work, I'm not the head of the fertility team, but I am one of the key figures that triage clients on which directions to go because we like getting it from the root. I mean, from the grassroots. Because once you make a good diagnosis, you edit the things that needs to be edited, you delete the ones that require to be deleted, you infuse
add
the
what needs
ones
to be
that need to
added.
be added, and you do the right procedure. Then you have prepared the individual, at least for a fair trial in assisted reproduction technology. So we see the men, we see the women, yeah, and we do all of that.
So I hope we're all learning today.
Wow.
In Alps Hospital, like Dr. Ken said, we do our best. We evaluate as much as we can to know even the tiniest reason why what you're going through is happening to you. I don't want to say it's going through you, but then we try to do our best, and we would love to have. If you know anyone that is going through this, and you really care about the person, please do well to send them down to us. We're always here to take care of them and their needs, and to give them the best care
Oh
as
yeah.
much as possible. So you were talking about thyroid for women causing miscarriages.
Yeah, yeah.
Does thyroid in men also
Yes,
impact?
please. Thyroid in men affects pumps. The thyroid gland, for instance. Yeah, for those who don't know, I have forgotten how to describe the thyroid.
Is
It's this soft tissue that it's in the lower part of the
at the
neck.
base of the neck.
It's very small and it looks like. Let me see. Like which plant
From
does it look like?
biology, it looks like a little H.
Yeah, good girl.
Yeah.
Looks like letter H with a connection in the
The
middle there, right?
connection,
How
yeah.
do you remember these things? Seem to have forgotten my biology. Yeah, so it occupies these two sides of the neck, right? Then
Yeah.
the letter H, the crossing in the H is in the middle.
Yeah.
This gland controls, it's like a midfielder in the body. It's a link between the brain and a lot other functions that the body observes, including reproduction. If it's abnormal, it affects the sperms. It affects the egg, it affects pregnancy, it affects reproduction. So when the sperms are also abnormal, you want to check what the thyroids are like. And remember, I said earlier that sometimes this investigation may not necessarily uh, show abnormalities, but you have ruled out the possibility of affectation from thyroid abnormalities. So it's okay to do it and it's normal. So we check that out for men. And those who have such abnormalities, you direct them to the appropriate unit for care. And sometimes these thyroid abnormalities may be so subclinical, may not be showing symptoms, I mean, gross symptoms, but could be bad enough to cause problems. So we check that for men.
All right. So
We
what are
check that
some
for men.
interventions? Maybe you've done your investigations, you've done some diagnosis. Let's say, for example, someone who has maybe low eggs due to advanced age. Is there what are some interventions that we can do for such people, maybe to promote the chances of their IVF being
Yeah,
successful?
when people have low ovarian reserve, for instance, automatically their chance of succeeding is low. Chances of producing eggs is low. Chances of having good quality of eggs are low. Chances of having pregnancy from those eggs is also low.
No.
So often, uh, everywhere in the world, women are addicted to their eggs. You know, so you say, okay, you give them all the options. Like here, we don't tell them what to do, actually. We just counsel them based on statistics, on what their chances of success
Chances.
are, and allow them to decide what they want. Often, even when the eggs are bad, women want to go with their eggs. When they choose that path, we just support them. Just make sure they understand the implications. But it's painful sometimes to see that a woman who knows she has no chance with her ex goes on with her ex, then has failure, and then comes back to the physician and say, "Why didn't I succeed?" So but then if they choose that path, you do what needs to be done for them. Ovarian rejuvenation using the PRP, precursor stem cells, and all of that could be done to just give them some good chance, improve on their chance. Or you place them on some supplements, for instance, the coenzyme Q10. The Q10, for instance, the coenzyme Q10 has effect on the mitochondria of the female eggs,
Okay.
because the mitochondrion is what actually affects the quality of eggs. As a woman is aging, the mitochondria is dwindling in quality, is becoming poorer. So the coenzyme Q10 actually improves on the mitochondrion, improve on the environment for egg production, and then a woman may just have some slight notch on improvement of quality of eggs. So those are some of the things. Vitamin D3, for instance, could be administered, and all other supplements. But it's good to mention at this point, women constantly say, boost my egg, boost my egg. There's no egg to be boosted anywhere. That's the truth. Don't you have drugs to boost the eggs? I say, man, your eggs cannot be
People
boosted.
said.
Your eggs are just defined in you the day you were born. Boost them to increase number? No.
No.
No, man. There's no such thing in reproductive medicine. It's only what you have that would be gotten. You can only improve the environment under which the eggs are produced, but you cannot boost the eggs. Now, a woman can have arrest of eggs like in polycystic ovary where the eggs are not being ovulated. You can give drugs to just push them to be ovulated, but you're not boosting them. They are there. You just activate them to continue in the process of
Of
a
release.
release. So women say that all that. I don't know medication to boost. My friend has egg boost, egg boost, egg boost, egg boost.
Which one is egg
You could
boost?
take a drum of egg boost and still have no eggs. So the word is activate the eggs. So is that what question did you ask? I think I've forgotten now.
Oh, I forgot to be talking about eggs. Okay, I remember.
Yes, donor eggs and all of that.
In interventions.
Okay, intervention.
Yes.
Yeah. So these are some of the things that could be done based on after evaluation. If a woman needs to have ovulation induction and timed intercourse, she goes that way. If she needs to have intrauterine insemination, if you think she's qualified for that, she goes that way. Then if she needs to have IVF, you determine what kind of IVF.
IVF.
IVF with her own eggs, IVF with donor eggs, IVF with her husband's or partner's sperm, with donor sperm, or even IVF with genetic analysis. Especially those who want to have some peculiarities in the selection of their kids,
Okay.
or some people who have abnormal genotype matching and all of that. So it all depends. Intervention can be anything. It all depends on these individuals.
So what about interventions for men that maybe have slow sperm?
You could give multivitamins if the problem they have can be improved on with multivitamins. Then those that have abnormalities with the testicles, like abnormal blood vessels, varicocele, they could have varicocelectomy. You could have 100 million sperms, but if there is varicose veins, the sperms will not be as healthy as they would have been if there were no varicose veins.
Wow.
Yeah, so it's better to take them out. you know. So they have varicocelectomy. Some men have hernia, for instance. And if you know what hernia is, it means that part of the intestines finds a way to get into the scrotum, and then you have a very huge scrotum. When you have this hernia, for instance, herniating into the scrotum, it means it heats up the testicles and the epididymis and the sperms and affect sperm health. So those hernias should be fixed before even IVF. Otherwise, you could be risking failure because of poor quality of sperms. So if it's hydrocele, for instance, you could also address the hydrocele. Hydrocele is collection of fluid around the scrotum that can also transmit heat and cause some stasis in the testis, around the scrotum, and then it could affect the outcome of fertility care. So you have to pay attention to details. The fact that somebody is coming for IVF doesn't mean that hernia repair
It's
is not
necessary.
necessary. You understand? So this can actually change the entire course of the IVF and improve on the man's health.
So if a man's sperm comes back fine, if his semen analysis comes back fine, is there any need to further do the hormonal testing that you talked about?
No, that's why I say these tests are individualized. If the sperm is fine, you may not need to go further with other testing with respect to the sperms, except if you want to check some other testings. Yeah.
So, Mr. Moni, I hope your question has been properly answered. So, we talked about like
Oh, was there a question I was answering?
yeah, it was a question
I
we were
didn't notice
answering
there was a question.
for a Mr. Money, K Money.
K money. I
Yeah,
like that. K money.
K Money.
That's a beautiful name. K money.
So we talked about varicocelectomy for men. Do women also, apart from the hysteroscopy that we all know about, are there other operational interventions for women who have fertility issues?
Of course, there are. If a woman has a fibroid, for instance, and then there are a lot of talks about fibroids. But we know that fibroid can compromise IVF, it can compromise pregnancy, it can compromise the health of the woman. So depending on the dynamics of the fibroid and how it relates to pregnancy, may want to have it removed. I've seen women with fibroids about 5 months pregnancy size, and
Wow.
we argue whether or not they should have those fibroid removed. If at the end of the day they choose not to, because you see, if you don't even remove the fibroid, sometimes it becomes difficult to do the egg collection by the regular route. You may have to do the egg collection through the abdomen, because fibroids, when it grows, it pushes the ovaries up, and then you may not be able to access the ovaries to pick up the eggs through the vagina. You have to do it through the abdomen, and even embryo transfer becomes difficult. So the best thing to do is to take out those fibroids for some people. you know Now, depending on the kind of fibroid, hysteroscopy can be done to remove it, laparoscopy can be done to remove it, and sometimes open surgery to remove it. Then a woman may have a fluid in her fallopian tubes, what we call hydrosalpinx. Hydrosalpinx are very toxic fluid materials. So you may want to address that. And one of the ways of addressing it may be to do a laparoscopy to clip the fallopian tubes so that the fluid doesn't communicate with the cavity of the womb, or you cut off the fallopian tubes because it means it is unhealthy to bring about pregnancy.
So if you cut it off, it means automatically the person has to do IVF.
Well, cutting it off is just helping the woman. It's just helping the woman because it's useless while it's there. It's a problem while it's there because it can give her chronic pelvic pain, recurrent pregnancy failures, and then God knows what else it can develop into. Acute abdomen. So it's better to cut it off. Yes.
Okay, so as for rounding up, Mr. Muffin David is asking, does low sperm make a man not last during sex?
I don't know about that. I have to study to find out.
Okay.
Yeah.
So Mr. David will study and would find out and get back to you. So with that, we've come to the end. We've come to the end of today's session. I really hope we enjoyed. So we just want to thank some of our viewers, Mr. Choice Elbuba, Mrs. Obedie, Mrs. Eunice Weng, Mrs. Opeyemi Faith, Ijoma Eze, Oluwatoyin, Mr. Radixon Dixon, and to all our viewers, really, we appreciate every single one of you for joining us in all of our sessions weekly. And we just want to thank you, thank you, thank you, thank you, thank you so much for all you do. With that, we'll come to the end of the session. Enjoy the rest of your day. Enjoy the rest of your day, and you know, stay safe, please.